Hello, my name is Matthew Petersen. I'm a PGY2 at the University of Florida in the Department of Internal Medicine. I'll be presenting an interesting case of hemorrhagic shock due to a unique origin. The case starts with a 66-year-old male with a past medical history of heart failure, paroxysmal AFib, CAD, hypertension, hyperlipidemia, who presented for subacute pain of his bilateral lower extremities and edema. He was diagnosed with cellulitis and exacerbation of his heart failure. He was given IV diuresis as well as trimethoprim sulfamethoxazole, and was discharged home with no complications during that admission. Of note, his PTT at the time was 35 seconds. 30 days later, he presented to the hospital with very similar symptoms as well as bruising this time. His PTT on admission this time was 60 seconds, and his iron ore was slightly elevated at 1.3. He was diagnosed with MSSA bacteremia and was treated with cefazolin as well as IV diuresis. On hospital day 6, he developed diffuse ecchymosis of his arms and abdomen. Due to abdominal pain, CT scan was done. It showed no signs of any internal bleeding. On day 7, he had increasing worsening ecchymosis. It was diffuse upper extremity, lower extremity, abdomen, as well as his neck. His PTT at that time was noted to be 117 seconds. His iron ore was severely elevated at 4.8. The next day, he had a hemoglobin drop to 5.5 from 8. CT scan of the neck was done, showing diffuse hematoma with a stable airway. This is an example of a CT scan. You can see hemorrhage and hematoma throughout the anterior strap muscles, but a patent airway at that time. He was transferred to the ICU due to hemorrhagic shock, requiring multiple blood transfusions. The missing study on hospital day 9 had a non-corrected PTT, suggesting the presence of a coagulation factor inhibitor. Factor VIII activity was undetectable at that time. The Nemagen assay was diagnostic for a severe factor VIII deficiency, and the factor VIII inhibitor assay was positive. The patient was then started on cyclophosphamide and recombinant factor VIIa. He had drastically improved hospital course and was able to be discharged later that week. So this is a case of acquired factor VIII deficiency. The incidence is low, 1 to 1.5 cases per million per year. It's an autoimmune response with an antibody targeted against strong clotting factors. It's diagnostic with a PTT that's elevated and a classically normal PT. A mixing study will not correct due to the presence of an anti-factor VIII inhibitor. The severity is measured with the Nemagen assay, which is a quantitative serial assessment of the factor VIII activity. The schematic shows anti-factor VIII antibodies that you would see in this disease inhibiting this side of the coagulation cascade. The EACH2 registry is a pan-European study that's the most robust of its kind. The registry includes most diagnostic cases in Europe of acquired factor VIII deficiency. Most cases are diagnosed as idiopathic, however, there are relations to pregnancy, malignancy, and autoimmune disease. Only about 4% are due to medication reactions, and only about 1% are due to antibiotic reactions. Treatment recommendations. For severe hemorrhage, the immediate use of a bypass agent is recommended. We used factor VIIa. This promotes the other side of the coagulation cascade. Oral steroids can be given, as well as cyclophosphamide. Both have equal efficacy, with appropriate response rate of about 80%. In summary, this is a case of acquired factor VIII deficiency. It is rare, however, can be a severe cause of hemorrhagic shock. Most cases are idiopathic, but there are some cases that could be due to medication reactions. Most are treated with steroids as well as cyclophosphamide with good remission rate. Our case, we thought it was either due to previous medication exposure, due to his antibiotics, or due to the base rate of the disease, idiopathic in origin. Here are my references. Thank you very much.